I'd like to warmly welcome you to our online seminars in ageing program. And it's great to see so many people online joining us today. I'd like to begin by acknowledging the traditional owners of the land on which each of us are meeting today. For myself, here at NARI, that is the Wurundjeri Woi-wurrung people. I'd also like to acknowledge the traditional owners of all the lands and waters across Australia and pay my respects to elders past and present, and to all Aboriginal and Torres Strait Islander peoples, including members of the Stolen generation. First, a little bit of housekeeping. At the conclusion of the talk, we will have some time for Q&A. If you have any questions, you can submit them during the seminar using the chat function, which can be opened using the chat tag at the bottom of the screen. Today's seminar is being recorded and will be uploaded to our website within a few days. So just keep this in mind if we have the Q&A at the end, if you're turning on your video to ask a question. So today I'm very excited because we're hearing from Professor Alison Mudge, and Alison is a Queenslander, as I have recently moved from Queensland, and I guess we've worked alongside each other for many years now. So Alison's a general physician, health services research and educator based at Royal Brisbane and Women's Hospital, and a professor at the University of Queensland. Her mission is improving the care, experience and outcomes of older people in hospital, and I don't know anyone that's more passionate about this subject than Alison is. She's developed and is the clinical lead for the Eat, Walk, Engage program, a ward-based multidisciplinary delirium prevention program, which has been successfully implemented in 19 Queensland hospitals. She serves on the steering committee of the Queensland Dementia, Ageing and Frailty Network and leads a multidisciplinary research team embedded in the healthcare system, collaborating on more than 100 peer-reviewed papers and several book chapters. So today, Alison's going to be presenting on improving hospital care for older people. So very warm welcome to you, Alison. Very excited that you're here presenting this seminar on behalf of NARI, and over to you.
Thanks so much, Tracy, and it's an absolute delight to be here today. I'm very excited by the NARI tagline, which is bringing research to life, and that really appeals to me on a number of fronts. And I think the first is, really thinking about aging and life, and how aging is such a important and natural part of our life. And I love this photo of 4 generations in my family with my frail and aged mother, who has another birthday this week, and right down to my beautiful little granddaughter who's only 19 months old, and at the very beginning of her aging journey. And really aging is an important part of our life. I think that we've really ignored aging for far too long and seen it as the enemy and something to be conquered, and that is absolutely not what aging is about. But we must be able to account for our needs and our society's needs right through the spectrum of our years of life, and that includes really engaging head on with some of the challenges and issues and complexities and opportunities that are exciting about improving care for people who are older. So it's very exciting to be talking today, and I'm very much at the applied end of research. And so what I'm also really passionate about is how we get evidence into practice. And for me, that really is bringing research to life. And so I'm going to talk a little bit about the evidence and what we know, but I'm going to talk a little bit more about doing, and hopefully finish with a bit of a challenge around doing. So what I'm going to try to cover today is to talk a little bit about why caring for older people in hospital is becoming ever more urgent and important. Why is hospital care for older people different? What does the evidence tell us about models of care that improve care and outcomes? But models of care is only part of the system, and how do we think about what's sort of being done really at system level to improve hospital care of older people. And I'm a hospital doctor. I'm going to be talking, I know that a lot of really important care for older people happens in the community, but my expertise is specifically in hospitals. And, you know, I think we all have experiences of important older people in our lives. This is Auntie Carmel, who's well into her 90s and still living independently. And she's had a number of hospital interactions over the last 10 years that have either made me feel reassured or very anxious about the state of our hospital system. And I think it's the experience and stories of our families, our consumers, our carers, that really help us to drive improvement and continually make things better. So why is this an urgent problem? Well, I'm just going to have a little bit of a storyline based on demographics here. And so this was the year that I was born. This is a population pyramid, men on the left, women on the right, and the number of population in each sort of 5-year or in each year segment. And you can see that I was born into a rocket-shaped demographic. I was born into a world of children. I was just at the end of the baby boomer generation. And there was a lot of attention in healthcare around meeting the needs of young families and children. Children's hospitals were really just getting off the ground. But by the time I was an intern in 1990, really the population demographic had shifted very significantly. That big number of children have grown into middle-aged adults. We were doing things in hospitals around treating you know, early onset coronary disease and cancer and things that were sort of killing the 35 and 40-year-old parents of my friends at that point. And we really made remarkable technical strides in healthcare to really improve those bad outcomes in both in children and in young adults. And that's where a lot of our philosophy of medicine and hospital care has come from, that emergent response to single system problems that have, you know, could be very much framed as the enemy to be treated. By the time I started really implementing the Eat, Walk, Engage program, which I'll be talking about later, really we were starting to talk in hospitals about the epidemic of chronic disease. So we can see that baby boomer generation continuing to move up. We've now got a lot of people aged between 45 and 65, a lot of diabetes, obesity, heart disease, other cardiovascular disease and cancers, all of which increase with aging. And so we're starting to see not so much just those single system problems that had often had good technical solutions, but the complexity of team management of people with multi-morbidity. Last year was when the start of the baby boomer generation hit the age of 75. And by the time I reached 75, I'm going to be amongst a very much larger group of people in the population. And you can see that the tip of this gumnut cap really hasn't changed over time. When I was a child, I had a great-grandmother who was well into her 90s. And so people have lived to advanced ages really throughout history. But it's going to be those sheer numbers of people. It is not the problem of the inverted pyramid that we're often tricked into thinking. This is not an age distribution where we're suddenly going to have nobody to care for vast numbers of older people, but it is a shift in what we can expect coming through the doors of our hospitals. And that's not just about numbers, and it is entirely predictable. And the reason that it's not just about numbers is because we can't talk about older people in hospital without talking about the concept of frailty. And however we measure frailty, whether we measure it using the Freed Frailty Index in that top graph there, or a frailty index that's a sort of a slightly more nuanced measure of frailty. However we measure it, frailty really starts to accelerate from the mid-70s. So the more of our population we see with an age over 75, the more frailty we're going to see. And frailty is that vulnerability to physiological stresses. And so frailty is particularly important when people have had an acute, severe physiological stress, which is acute illness or injury or surgery. And so frailty is a particular problem within the walls of the hospital. And how we estimate frailty, and again, there's a plethora of different measures, and our estimates will depend to some extent on the measure that we choose to use. But this lovely review by Doody, published a couple of years ago, looks at pooled frailty prevalence across different areas of the hospital. And you can see really certainly in the general medical wards that are my sort of natural environment, psychiatry wards, neurology wards, rehab wards, well over half of the patients that we're looking after now are frail, and a significant number are also what we might call pre-frail, so might not reach those criteria for frailty, but are still, well, are certainly not robust. And as time passes, we're starting to see more and more patients within specialty areas who are also experiencing frailty. So I'm going to talk for a few minutes about why frailty is important in hospital and what it tells us about how we might care for people, because I think we often have very black and white thinking. We think of frailty as yes or no. We think about its impact as a black and white kind of impact, and it's quite a nuanced problem. And this is my favourite way of thinking about frailty. This is some beautiful work by Andy Clegg, really trying to articulate what it means to be frail. And he explains it using these two lines. So the green line is someone who is less frail. Frailty is a continuum. So someone who is less frail, perhaps one of us, and who is very independent in their normal activities and functions. And when we encounter a minor illness, he used the example of urinary tract infection, but I think COVID has given us a lovely example for this as well. So if one of us develops this illness, this might make us feel sorry for ourselves. We might try and get out of the dishes. We might spend a couple of days away from work with a minor illness, but we will bounce back pretty quickly unless it is a very big insult to our health. And we will be very unlikely to require hospitalisation for minor intercurrent illness. In contrast, someone who is moving along the frailty spectrum, who is not yet fully dependent or perhaps dependent in any of their basic activities of daily living, but is starting to accumulate the multimorbidity and perhaps social and cognitive and physical disabilities that add into this concept of, I guess, wear and tear and development of less resilience to stress, are going to potentially have a very different course. And there are three really important parts of this graph that I want to highlight. So the first issue is that the same illness is likely to cause a bigger functional impact, and it might have an impact on physiological function, on physical function, on cognitive function, but that impact is going to be bigger for a person who's more frail. That's what it means. And because people who are more frail are already closer to the line of requiring assistance with their basic activities of daily living, then that means that that drop is much more likely to put them in a situation where they need physical assistance and careful monitoring of their health condition. And that's really what hospitals were originally designed for. That's what we do in hospitals. And so it is predictably much more likely, as our population becomes frail, that there will be an increased need for admissions to hospital. And there is plenty of empiric evidence to back this up as well. So more hospitalisations are not a failure of the system. They're not a failure of primary care. They're not a failure of frail older people. They're exactly what the concept of frailty would predict that we need. And to say that we need that the solution is to just keep people out of hospital when in fact their hospitalisation needs are higher might lead to some fairly perverse outcomes. So that increased need for hospitalisation is a predictable outcome. But it is also a predictable outcome that if this is mediated by this sudden decrease in physiological, physical or cognitive function, that might be disproportionate to that initial actual physical illness insult, then people might present with much more diffuse presentations. So they might present with a geriatric syndrome, they might present with a fall or a delirium or just with functional impairment as a response to a whole variety of different illnesses, and that we may not see the same specificity of presentation that we do in a younger and more robust person, where it's the symptoms of the illness themselves that come to the fore. And so this leads to atypical presentations, and that is even more confused by the fact that these are often patients who also have multimorbidity, and that means that they might be on multiple medications, and these might blunt the normal physiological responses. They may not develop the same degree of tachycardia if they're on beta blocker drugs. They might not develop a fever if they've got immunosuppression. So there are a whole range of reasons why it can be more difficult to unpick what is the illness that has triggered this decline in physiological, physical, or cognitive impairment. On top of this, providing a good account of your illness presentation requires significant perceptual, memory, judgment, and communication skills, which are often lost in processes of cognitive impairment and dementia. And so eliciting a good history and eliciting clear signs of illness can be much more difficult in older patients who are more frail. On top of this, we might have ageist stereotypes within our hospitals where we have a sense of therapeutic nihilism about the outcome of older people. And all of these lead to challenges with assessment. We might not recognise what's normal ageing versus pathology because of some of the stereotypes we have. And all of this has been clearly demonstrated to lead to diagnostic delays. Now, today is Patient Safety Day, World Patient Safety Day, and diagnosis, early and prompt diagnosis is sort of the theme of this year's World Patient Safety Day. And I would argue that, our older patients are the ones who are particularly at risk of having delays and inaccuracies in diagnostics for all of these reasons. And that then sets a cascade of events where they're going to have delayed plans of care and delayed treatment that will cause further harm later on. So increased need for hospitalisation, more challenging assessment. The next part of this little figure is really around that period of recovery. So it is predictable, if you have lower resilience, that you will have slower recovery. And for hospitalised patients, that means longer hospital stays. Again, this is not a fault or a problem with the hospital, with the patient, with the care. This is a feature of slower, of less resilience. That's a feature of frailty. And so we have longer hospital stays. And we need to plan and predict that that will happen. But of course, what that provides all the greater opportunity for is hospital-associated harm. So the sort of harms that happen in a busy, chaotic, pressured, time-driven environment that older and frailer and patients with cognitive impairment in particular don't fit into very well, means that these patients are more likely to acquire hospital-associated harm, and I'll talk about what I mean by that in a moment. And they are already more vulnerable to any physiological stress. So we create this cascade of worsening harm. And again, a simplistic response to that might be, well, let's just keep people out of hospital. But that doesn't actually address the problem, that hospitals must be designed for the people they care for, and our systems should not be perpetuating hospital-associated harm. So what do I mean by hospital-associated harm? I'm particularly interested in the complications that can occur regardless of the admitting condition you come in that are more common in older people. And these 5 complications in particular share a number of common risk factors, particularly frailty, age, cognitive impairment, functional impairment, and poor nutritional impairment. And again, this week's a very exciting week, isn't it? Because it's both Malnutrition Awareness Week and Dementia Action Week, and cognitive and nutritional impairment are 2 really important risk factors for really all of these complications. These are very common complications in our system. This is data from a prospective study in medical and surgical patients aged over 65 on general wards. All patients are aged in hospital for 2 days or more. And we've had a lot of focus, particularly on falls and pressure injuries, which are very well documented now, well documented by our hospitals, well documented in coding. But what we're still seeing really underrepresented in our hospital data is these big three of delirium, functional decline, and hospital-acquired incontinence. And if we look at those three complications, they are also really mutually reinforcing. So patients who have delirium are more at risk of functional decline and developing incontinence. People who develop incontinence are more at risk of further functional decline because we immobilize them with continence management devices. So these are mutually reinforcing complications. What this means that we found that any one or more of these complications occur in almost half of older multi-day stay patients. And so these are very common experiences. Each individually is distressing for patients. They also often cause distress for families and for the people caring for them, and they all carry additional costs. They are all more common with frailty. So this is some unpublished data from that study. And you can see this significant graded increase in delirium, functional decline, and this composite outcome of any hospital-associated complication with increased frailty, so that almost 2/3 of our more frail patients, those with a frailty index of 0.4 or more, are going to experience one or more of these complications during hospitalisation. And if we look at the number of cumulative complications, just of these 5 complications, we also see it as the frailty index increases from 0.25, which would be considered robust, through mildly frail to severely frail. We are more likely to see patients accumulating multiple complications. So it's not enough just to prevent falls. We need to be preventing delirium. We need to be preventing functional decline. We need to have systems that address all of these together, because just preventing one is not enough. And we've shown very clearly that accumulating more than one of these produces a progressive and graded increase in future poor outcomes, including the number of days spent in hospital, the likelihood of going to a place other than home on discharge, and 6-month mortality. So these complications have really important implications. And if you think about what gets charted in hospitals on admission, we're much less likely to chart those kind of risk factors of dementia and malnutrition and functional status and frailty than we are to think about individual morbidities. And I think our system really needs to change around that. So the third part of this model is often a failure to return to that normal level of function. And that means that you're going to be more at risk of a second hit. If you have poor care in hospital and acquire additional complications, you can see that your outcomes will very readily shift to even poorer recovery. That potentially can be the thing that leads to non-home discharge. And so that greater hospital care, post-hospital care needs, whether it's in the community with additional care needs from your informal carers or from care services, or whether it's premature discharge to residential care, these are really important implications and really highlight the importance of getting that care in hospital right. So if we think about that model, it flows that there are areas of important improvement that can help us with each of those areas. And the things that might be expected to help and for which there is good evidence now of improved outcomes for older people are making sure that we've got that early assessment and prompt diagnosis happening really from the front door, that we have a proactive rehabilitative approach right from the beginning to functional, nutritional, cognitive recovery concurrent with our medical treatment, and that we recognise the need for support across transitions, and that there will be anticipated higher support needs after hospitalisation, and that we need to plan for that in order to support our patients, but also importantly to support their care partners in the community. And beneath all of this, underpinning all of this, is a really good understanding of who this person is and what matters to them, so that we can make the choices and and preserve that autonomy and dignity for patients really throughout delivering those evidence-based models of care. Now, in an hour's presentation, I haven't got time to present the evidence for all of those, so I'm going to really focus on the bit that I'm the most qualified to talk about, and that's really how we prevent hospital-associated harm during hospitalisation. And I'm going to focus in particularly around delirium prevention and how we might bring the evidence around delirium prevention to life. So we can't talk about delirium prevention without talking about the amazing work of my colleague and mentor, Sharon Anui, who has really made enormous contributions to understanding delirium, and began with really careful observational studies of understanding who was at risk of delirium. I was able to demonstrate that age, previous cognitive impairment, sensory impairments, frailty, functional impairment were all really important predictive factors, and that those are things that create cognitive vulnerability for us. And if we have very high cognitive vulnerability because of cognitive or sensory impairment or frailty, then we don't require a very large insult to create acute brain failure, which is what delirium is. Whereas if we have very low vulnerability, if we have very robust cognitive function, then we might need a very severe illness to provoke delirium. Any of us can experience acute brain failure or delirium given sufficient insult, and it can occur in babies, children, adults, and older adults. But because of the accumulation of risk factors over our lifetime, it does tend to be much more common in older adults. And the insult that causes that, the surgery or the illness or the medication or the injury that might cause that, is often something that we can't do something about. But her experimental work really showed that there were very important things happening within the walls of hospitals that precipitated delirium independent of that initial noxious insult. And that is things like inadequate nutrition, dehydration, restrictive practices, including, drips and catheters and rules about mobilising, changes to usual routines and sleep, pain, and many of the medications that we use, particularly anything with sedating side effects. And that what this meant was that even though we might have people who are vulnerable and who have an initial precipitant, that doesn't necessarily mean that they'll come in with delirium or that they're going to develop delirium. But if we don't get that care right during their stay, then we are going to see much more delirium than if we do get the care right. And so she devised, as a test of that hypothesis, she did the first delirium prevention trial in the Hospital Elder Life program. And this was really looking at those risk factors and trying to deliver individual protocols through some carefully trained volunteers who were actually nursing and medical students who were required to do mandatory hours of community service in her initial training. And she was able to show for the first time that you could reduce delirium that happened in hospital very significantly, from sort of about 15% to about 10% in those wards. And that really led the way for replication of that model in many other sites. An initial meta-analysis certainly showed a reduction in delirium across those studies of almost 50%, and really quite high homogeneity. So really a fairly consistent effect across those studies. And then more recently, the most recent Cochrane review on preventing delirium in hospitalised non-ICU patients has really tried to tease out a number of different models, not only Hospital Elder Life program, but other models that have really focused on trying to address those in-hospital risk factors that you can see listed there that are clear risk factors for delirium, and addressing them in a systematic way with a multidisciplinary team. And that review has again really shown a very consistent approach on medical patients in the top forest plot, surgical patients in the bottom forest plot, and really a reduction of 43% in the risk of delirium through implementing such programs. So not trying harder, but implementing not multi-component non-pharmacological programs, which is quite the mouthful, isn't it? And really this shows that at least 2 in 5 cases of delirium can be prevented. So there is now, this is the highest level of evidence that we have in healthcare is level 1 evidence, meta-analysis of multiple randomized controlled trials in different countries, different settings, really showing a very consistent effect. But the challenge is, how do we actually do it? How do we bring that research to life? What does that mean? And the uptake has been remarkably slow internationally for this evidence. And that's for a number of reasons. Change is hard, and this kind of change is really hard because it involves multiple different strategies. They all sound simple in themselves, but they're responsibilities of different disciplines within healthcare. And that kind of change is difficult and involves negotiation. Delirium occurs in medical wards, surgical wards, intensive cares, all sorts of settings, and how we might address those basic fundamentals of care will really look different in those different settings with different resources and different skill mix and different staff mix. And so we really need to think about that context, and probably a one-size-fits-all is going to be difficult. But fundamentally, and this is very important this week in dementia awareness risk, we really lack knowledge around cognitive impairment as a society, as hospitals, as a representation of those society. And in particular, we're still unskilled in recognising delirium and delirium risk, particularly dementia. And I think we're steadily improving. There's been a lot of work around this, but we've still got a long way to go. And then, the fundamental problem is that if you have a patient if you've got 4 beds that you're looking after as a busy acute care nurse, you've already got 1 patient who's come in with delirium or developed delirium, your care needs for that patient are much higher than for the other patients in the room. And it is going to be very difficult for you to provide the time and care to provide good preventive care for the other 3 patients in that bay. And so we struggle all the time with this balance between treatment and prevention. But it is very important that we address this because the evidence is so much stronger for prevention than for management. In fact, management strategies are the same strategies, so at least we can take a consistent approach, but we're more likely to see benefits in prevention. And this, the bottom line is that this is why it's not about trying harder and why we need an active ingredient, which I'm calling agency, to be able to bring the multidisciplinary team together to understand the context you're working in, understand where your strengths and weaknesses are, skill up your staff, and get your environment functioning better to implement delirium prevention strategies. So I'm going to talk a bit about our experience with the Eat, Walk, Engage program, which is a proven delirium prevention program. So I'd like to introduce my team. I work with an amazing team. This is the team for the Royal Brisbane and also for running our statewide program. And the important thing about this team is that we're a truly multidisciplinary team. So we have represented here medicine, nursing, occupational therapy, dietetics, physiotherapy, administrative support, data management support. And we all bring unique skills, perspectives, both from a clinical and a non-clinical and research perspective that have all been crucial in addressing this really wicked problem. So, delirium prevention and in fact care for older people generally is the ultimate team sport, and we need to really, a really important thing is bringing together your team. The second important thing I want to point out is that we use this very specific implementation framework. We recognise change is hard, and there are good frameworks for helping with change. And the framework that really works for us, that appeals to us as clinicians managing complex change in complex healthcare environments is this one. And that is why our program is founded on the concept of facilitation, or making easier, and the specific role of a facilitator. And I haven't got time to talk really more about that. The third thing I really want to point out is I'm going to be talking about various parts of this journey, but this has been a really long journey and it sounds awesome when we talk about it now, but this has been the culmination of steady, iterative improvement informed by our patients, informed by our staff as we've moved along, and that's really important to understand, and I'm going to give you some highlights of, but but it certainly is not something that's happened overnight, and it requires, really sustained investment to develop these kind of programs. So what is Eat, Walk, Engage? Eat, Walk, Engage is a structured, ward-based continuous improvement program to improve care of older people. And it has 5 core components. The first one is listening to our older patients, and we do this through a number of mechanisms, including regular interviews with older patients using appreciative inquiry around what's working well on this ward, what's not working so well, what are your suggestions, what are the barriers to eating and walking and engaging, and how can we make it easier. And we explicitly take that perspective and summarize it and bring it back to our teams to try to understand what it really feels like to be cared for, because it's very easy as health providers to come up with solutions that don't match the problems that are experienced by our patients. The second component is the Eat, Walk, Engage facilitator. This is a resourced position, a nurse or allied health who we train both in gerontology and in implementation science. So we train in the evidence of how to improve care for older people and in the evidence of how to bring teams along in change. And that's really important because they work very closely with a multidisciplinary work group on each team, that the owners of the tacit knowledge of the culture, context, resources on this ward, what makes people proud, what makes people wish they could do better. And they work with that team on a regular meeting basis to create a common vision for improvement that responds to what our older patients are saying. And they do that with the assistance of a multi-professional allied health assistants, again, a small resource, a half-time resource for each ward, who can take delegation from any member of the team around the core principles of the program, which is eating, walking, and engaging, as we saw earlier. And then, very importantly, we have some well-developed measures of fundamental care, the cares that are so invisible usually in our healthcare system, that help to inform both where we're at now and whether we've made improvement, both at ward level and at program level. I'm going to talk very briefly about those. So that all sounds lovely. Does it work? Well, yes, it does. So we've proven in a cluster randomised trial involving 4 hospitals in southeast Queensland. 1 ward did the intervention, 1 ward did whatever else they like, but not our Eat, Walk, Engage program, in a representative sample of older patients, that we were able to significantly reduce delirium to a similar degree to seen in all of those other studies. In real terms, that means that instead of 1 in 3 people developing delirium on the ward, 1 in 6 older people develop delirium. Think about what that might mean for your workload as a staff member on those wards. And we also saw promising trends in all of our other outcomes that have been sufficient really to make argument around why this program should be implemented. But what does it actually mean at the bedside? What does bringing it to life look like? This is the kind of scene that you might see on wards where, and these are the kind of things that our patients often tell us, that meal times are busy and chaotic, that they're often not well managed, that they're not well positioned, and that it is often a very lonely experience. And we work with that kind of feedback from patients in order to create change and improvement. And the improvements that I'm showing you look lovely. They're the culmination of many weeks, months, even years of discussion and negotiation with different team members to get to where we are. But these are on busy acute medical wards, opportunities to sit people out, to provide a more social environment for eating. And that way people need less assistance, they're able to eat more, and they're less likely to experience aspiration. And we have been able to show, now that we've rolled out the program, that we can see slow but steady improvement at scale. Over the first 2 years of Eat, Walk, Engage statewide, we've seen an improvement from about 1 in 5 patients sitting out when a mealtime arrives through to about 1 in 3 patients sitting out. And if we think about how that sort of scales up across multiple wards, you know, these small changes, small iterative changes can really start to make a difference to patient outcomes at scale. Similarly, we know that we are in cluttered environments, busy staff. Patients often feel that they feel intimidated by trying to walk in in our wards that seem to be arranged. I don't even know who they're arranged for. They're not easy to navigate for our staff or our patients, are they? And they're reluctant to ask for help because they can see how busy our nurses are, and reluctant to try and set out for that distant window because there's no way that they're going to be able to navigate that or find their way back to their bed. And we've been able to create changes in our wards that actually provide some permission around exercise, that provide opportunities for safe, opportunistic exercise, that provide a sense of teamwork and fun and engagement around mobilising. And again, this takes a lot of negotiation. Space is very tight. This isn't a rehab ward with a gym. This is just in a corridor on acute wards. But we're able to create that sense of permission. And part of how we've been able to do that is through robust measurement of mobility. And we have this great mechanism of observing physical and cognitive activities that I haven't got a lot of time to talk about, but basically involves 8 hours of continuous observation of all the patients across the ward. It gives us very robust information about physical and cognitive activity. And for example, on our second ward that we ever implemented on a vascular surgical ward, we were able to see the amount of daytime spent upright and active increased over the year from 3% to 9%. Now that sounds like quite a small increase, but that represented a lot more patients actually ever seen to be upright and active, and it translated into a reduction in functional decline on that ward. Now, this is a vascular ward, lots of amputations. Mobilising patients offers a whole bunch of difficulties that needed to be overcome, but we have shown that we can improve. Similarly, our hospitals are anaesthetic. There's often nothing to do. Patients are very aware of this, that lack of things to do results in cognitive decline, results in mood decline. Trying to provide opportunities for socialising involves a lot of creativity. And so we have beautiful programs in many of our hospitals, our beautiful Delta dogs that come in visiting with dogs, that provide somewhere for patients to walk to, opportunities for reminiscence about their pet, sense of connection with community, right through to, this is beautiful pictures from really quite a complex day of activities in one of our hospitals around the Eka. That's our royal show in Brisbane. And this is a team who worked together to create a whole bunch of show-themed activities for patients on the ward. And you can see the sense of fun, teamwork, both for patients and for staff. So this is about really supporting our patients and staff. And this is an example on a ward of the way that we might measure that. The purple bars show the amount of daytime that are spent doing cognitively engaging activities. And you can see a reduction in time spent just sleeping during the day and an increase in time. This has taken a long time. This is multiple cycles of improvement. And you can see that the data went backwards in 2022. 2022 was a terrible year for our program because we couldn't do those group activities and cognitive engagement. So we also have to be flexible and recognise big things that are happening in the context like a major pandemic and create really creative solutions to those. So that's an example of a model of care, and there are many models of care that help older people, but we need more than models. We actually need to change the whole culture of our hospitals, and there is some beautiful work happening internationally now beyond models. And an example is the 4Ms framework, the age-friendly health systems work that's been promoted by the IHI and the John A. Hartford Foundation in the USA over the last sort of 4 years. You can see a lot of similar themes coming up there with what I've already talked about and the Eat, Walk, Engage program. There is a senior-friendly care framework in Canada that really thinks about what are those big organisational and cultural enablers behind delivering these good models of care. What does it take from the point of view of leadership and care processes and cultural environment and physical environment to be able to deliver that? And that's been quite influential in work that I've been able to lead here. This is a slight modification of that Canadian framework that we were able to do through what was the statewide Older Persons Health Clinical Network here, which is now a Queensland Dementia, Ageing and Frailty Network. Some work we did a number of years ago looking at how using those concepts from senior-friendly hospitals and looking at how we're doing. Now, the pink and blue boxes, evidence-based assessment and management is and connected systems is what I'm talking about with care models. But all the other boxes are really about the pieces that you need to have in place in order to deliver those care models. And you can see that while we were perhaps had established systems and developing systems for the care models, we've still got lots of gaps in terms of our executive leadership, organisations caring about older people and dedicating resources towards older people, genuinely involving older consumers in the operations of our hospital, in planning improvements. How do we involve consumers who are living with dementia, who are living with frailty, who attending committee meetings might be really challenging and need a lot of support, but we can't just exclude them from our conversations. Huge gaps in training our staff across all disciplines, and this is probably the thing that we need to be doing the most urgent work around. And while we've got some special units with beautifully designed environments, and we know the principles of good environmental design for people with cognitive and physical engagement, still really limited application at organisational level. So that is, we still have enormous gaps in our systems to try to support these models. And until we start to really address those, we're going to struggle. And I'm just going to finish with some nice examples in Queensland. So I think in terms of clinical and executive leadership, we were very fortunate here to have the Queensland Frail Older Persons program. And going back to my sort of original concepts, this program supported the JEDI program, Geriatric Emergency Department Intervention with early prompt diagnosis, our Eat, Walk, Engage program in the wards, the RAS program coordinating care in and out of hospital for our most vulnerable patients from residential care, and our advanced care planning program really supporting understanding what goals of care are and how we support them. And that was a $30 million recurrent investment from the Queensland government, a ministerial priority that has really made an enormous difference and really allowed clinical leaders to lead these programs of work. And that's made a real difference for our program. So moving from a ward-based program now to a system-level program across Queensland. We've got sites now for Eat, Walk, Engage, 49 wards in 18 hospitals around Queensland. And that really enables us to engage with clinical leaders right across the state who have creative solutions and who can share solutions. It enables us to really start to benchmark data around some of the invisible things in our hospitals, like the amount of time that's spent mobile. We've got robust data collection. We can benchmark. We can use data to set what might be good practice. How would we define good practice with some of these measures? And so that kind of executive and leadership visibility is really important. We're very proud of the work that we've been able to lead with our consumer response team. So we have a statewide consumer response team that's been recognised by the Australian Commission on Safety and Quality in Healthcare, led by a passionate consumer whose life mission has become bringing awareness to delirium, given her family experience with it and what a traumatic experience that was. So very exciting to be working with consumers and really working with staff. So building 2 new workforces, our facilitator workforce who we train and mentor, our multi-professional assistant workforce who we provide continuing professional development for, and then really working with teams from the wards, doing one-day multi-professional workshops on caring for people with cognitive impairment. That gets just the most, fantastic feedback from our participants. But we feel that, this is nowhere near enough progress. We've got so much more to do, but really working with staff is such a joy and such an important thing to do. And then we do some high-level advocacy. We've been able to advocate, for example, through the Queensland Clinical Network for Dementia, Ageing and Frailty, to try to put in design principles for cognitive impairment in hospital that is intended to inform all health capital division. Whether that will happen is a continual advocacy battle, but at least we've got some policy there. And then continuing to work with wards around small changes in small spaces that might provide an opportunity for comfort, pleasure, orientation, family connection. That is so important. So that's a quick cook's tour of some of the system level interventions that are possible. None of this is possible without amazing teams. And what I would implore you, if you want to start improving, it is really important to find friends, build a team, and it must be multidisciplinary. Really listen to your end users. You must engage with your consumers around what the problem is, with your staff around what's going well and not going well. And some of that engagement can be challenging. You really need to engage with in evaluating programs that you do put in, and that might involve working with researcher colleagues. And we really need to bring leadership on board with us. And so they're things that require attention if you're going to embark on this journey. But we absolutely all need to be on this journey, because I just want to close with remembering that this isn't us and them. This isn't us and older people. If you're not ready to advocate on behalf of the older people that you love and the older people that you care for, at least start advocating now for the older person that you are very, very likely to become, because it is a long journey and we've got a lot of improvement to do. Thank you very much.
Thank you so much, Alison. That was a fantastic presentation, and I think everyone's got a lot out of that. We don't have a huge amount of time for questions, so I'm going to ask a few that have come through the chat, and I'll paraphrase a bit. So hopefully, if you don't find that does answer your question, maybe just pop that in again in the comments. But one of the questions was about hospital in the home. A couple of people asked about it, and how well is it working? Is this the best way we can reduce these hospital-acquired conditions that older people particularly seem to get? Or is it actually going to just shift it to a different setting and they're still going to get those problems?
Yeah, so great question, and I have a biased answer to this because I'm a hospital doctor. I think there is a place for initiatives to try to keep people out of hospital, but I worry that as a policy approach, it's missing the point that we actually need to have better capacity in our hospitals. There's a predictable need. I put up a picture of Auntie Carmel early on. Her hospitalisations have been for an open fracture of her leg from falling off a ladder while she was putting up curtains, for a fractured neck in a car accident, for a ischemic gut that required an operation. They're the only times she's needed to be in hospital. None of that can be managed with hospital in the home. These are, this isn't about, we have this terrible stereotype about people with dementia or people with frailty occupying beds that were designed for middle-aged people with a single problem, right? That is a problem with our design. It is not a problem with who's coming in. We've got to be careful about the rhetoric of hospital substitution. Where it's appropriate, that's fine. But, we run the risk of building, in Queensland, we've built these satellite hospitals to meet this need that isn't the need, and we are still struggling every day with overfilled hospitals. Made no difference to hospital demand. So we got to make sure we're treating we're managing the right demand. Yeah.
Thanks, Alison.
Palatable response.
Yeah. Speaking of the intergenerational thing, someone's asked, how relevant is this sort of framework to younger people that get frailty? Like, we know people that have organ transplants. Sometimes
good care is good care for everyone. If we can get our hospital care right for older people, it will be right for everybody. And so our Eat, Walk, Engage program is targeted for older people, but it's a ward-based program, and our young women in hospital for a long time with their eating disorders and terrible malnutrition benefit from the program, as well as our older people. So yeah, if we get this right for older people, not going to hurt our younger people.
Yeah, fantastic. Mary's asked about co-designing frailty prevention activities, and have you got any experience with this? And is there evidence that it's effective, more effective if you involve, consumers in the design?
So my answer would be that everything is more effective if you involve the users in the design, and in the hospital setting, our users are our consumers, our carers, and our staff, and it's really important that we involve all of them so everything works better. The idea of frailty prevention, if you go back to that picture, the Clegg diagram at the beginning, the beautiful idea was, well, why can't we just make the difference between the green line and the red line less? Like, stop frailty, bring everybody back up. And there is, a little bit of evidence for frailty prevention, but gosh, we're still a long way of seeing that work at system level, at community level. We are always all of us are going to ultimately become frail, and we still, frailty prevention is important, but in the meantime, we've got to deal with people who are already frail as well.
Yeah, absolutely. I think some of it is we want to compress that morbidity to as short a time as possible, but it's not realistic to think that it's not going to happen, which I think is some of the rhetoric around now with the sort of anti-aging enthusiasts is very much around that, and it's, I think, quite misleading people.
And it actually builds on an ageist rhetoric.
Yep. Yeah. Another maybe loaded question for you particularly. It's been asked, as admissions of older people increase, should they be admitted under the care of a geriatrician-led team in the first instance?
Yeah, so in my hospital, 70% of patients of bed days are over 65. 40% of people have cognitive impairment. 60% of patients in my service have frailty. There are actually just not enough geriatricians to go around. So while it's a lovely idea that this would all be expert-led, I guess that my passion, I'm a generalist, I'm a general physician, not a geriatrician, although all my research is in older people. But that was, that has really come from the passion of how do we learn from what geriatricians are doing, and how do we take those principles for every patient, because, we don't have a workforce for specialist care of everybody. We really need to create those principles as the standard of care. And so I think we need a mix of both. We absolutely need specialist geriatrician care for people with more complex geriatric syndromes. But I think for the everyday, every orthopedic surgeon, every physician, every emergency physician needs to understand the principles of caring for older people, because it is our bread and butter, and it will continue to be for the foreseeable future.
Absolutely. And I think that's a fantastic thing to finish on. It's great to finish on. And if everyone can please join me in thanking Alison with your clap reactions online, that's great.
Thank you so much.
Before we end off, I'm going to hand back to Jess, who's just going to talk about some upcoming events, I think.
Thank you, Tracy, and thanks so much, Alison, as well. I just wanted to let everyone in the audience know that this Friday is our annual summit, where we'll be addressing the topic of human rights, our older people's rights too. It will take place from 9:30 to 3, and we have a host of really good speakers lined up. So for all of those who are joining us online, it's actually a hybrid event, so you're able to join on the day too. And I would just pop the registration link in the chat box. Registrations close tomorrow for in-person registration. So if you are in Melbourne and able to come in person, please jump on and register. Thank you.
Thanks, Jess. And next month, we're going to have Professor Miriam Moranti from the University of Canberra School of Politics, Economics and Society present for us. So she's currently a visiting scholar at NARI. So please join us online next month on Tuesday, the 22nd of October. And thank you for attending today.
Thank you.